So the next disease is Niemann-Pick disease. Here we have deficient enzyme sphingomyelinase and the accumulated substance is sphingomyelin. Classical history is a previously well healthy child, and then there is a history of weakness, loss of motor skills, enlarged liver and spleen, that is hepatosplenomegaly on physical examination. Classical finding is cherry red spot which is seen in macula. Also we have foam cells which are lipid laden macrophages. Now talking about cherry red spot, we have this differential diagnosis, Niemann-Pick, Tay-Sachs, CRAO, that is central retinal artery occlusion. To differentiate between Niemann-Pick and Tay-Sachs, this is the classic differentiating feature which you all should remember to differentiate them in MCQs. So talking about Tay-Sachs disease, the deficient enzyme is hexosaminidase A and the accumulated substance is GM2 ganglioside. History is something like this: 3 to 6 months old infant. There is developmental delay, hyperacusis, sometimes that it is seen, exaggerated startle response. The differentiating feature is the cherry red spot. In Niemann-Pick and Tay-Sachs, in both of these diseases we can see cherry red spot on macula. But in Tay-Sachs there is no hepatosplenomegaly, while in Niemann-Pick we can see hepatosplenomegaly. Lysosomes with onion skin is a classical pathological finding seen in Tay-Sachs disease. The last lysosomal storage disease, which is not as important as others, is metachromatic leukodystrophy. The deficient enzyme is aryl sulfatase A, while the accumulated substance is cerebroside sulfate. Classically seen in 2 years old child with central and peripheral demyelination with ataxia and dementia. So that is all about lysosomal storage disease. The main important features which you should remember is the differentiating features between Gaucher's and Krabbe, the deficient enzyme, and the differentiating features between Niemann-Pick and the Tay-Sachs about the hepatosplenomegaly, and the classical triad seen in Fabry. These are some of the most important points which are included in many MCQs. Now we should talk about mucopolysaccharidosis, in which we have Hunter and Hurler syndrome. In both of these syndrome, we have the accumulated substances which are heparin sulfate and dermatan sulfate, but the deficient enzyme is different in both of them. So that is one of the differentiating feature very oftenly asked in MCQs. So here in Hurler syndrome, the deficient enzyme is alpha L iduronidase, while in Hunter syndrome, the deficient enzyme is iduronate 2 sulfatase. Hurler syndrome is autosomal recessive, while Hunter syndrome is X-linked recessive. Hurler syndrome is classically seen in first year of life, while Hunter syndrome has a later onset, like in 1 to 2 years old children. Classical features seen in Hurler syndrome, they are coarse facial features, developmental delay, hirsutism, skeletal anomalies, airway obstruction, clouded cornea, hepatosplenomegaly, dysostosis multiplex. Radiographic findings in Hurler syndrome are enlarged skull, abnormal ribs, and spine. While the classical features which are seen in Hunter syndrome, all the features which are seen in Hurler in a mild form. So all the symptoms are seen in Hunter, plus one differentiating feature is the aggressive behavior. The child has trouble sitting still. It can mimic ADHD. And the most important differentiating feature is there is no corneal clouding seen in Hunter. So this is one of the most important feature which differentiates them both, Hurler and Hunter, in MCQ especially, that in Hurler syndrome there is clouded cornea, while in Hunter syndrome there is no corneal clouding seen. In the next video we'll learn about the glycogen storage.